Hello, welcome for this afternoon discussion. It's my great pleasure to start the discussion which Marek Trneny prepared with Michal Anděl. I'm looking forward extremely, and it's my great pleasure to welcome the panelists, the speakers, Professor Trka, Professor Campo, Professor Trneny, and Professor Hermine. Yeah, that's it. Maybe Michal would like to say more words, and Marek.
Yeah. First, I would like to welcome everybody. This is a Action Learn Society, and specifically a section of biology and medicine. We are very pleased that Marek Trneny prepared this afternoon symposium, and symposium will be offered to extreme big change which happened in last decades in the field of hematology. When I was medical student, which was some 55 years ago, to be hematologist meant that man should be able to fulfill many certification of death because of prognosis of the patients was very poor. And I think that time the medical students were not too much attracted to this field. In this field changed nearly everything. First, the small babies and small children with acute lymphatic leukemia got much better prognosis. There is Hodgkin lymphoma, and that's what I'm saying, not being a hematologist. And later, the same happened with adult patients. In this direction, we can speak about the miracle which happened in one field of the medicine. Since I'm not, my field is diabetes and endocrinology, and I'm not able to speak more about the field which is not my own. But generally, I hope that hematologist people working with cells of the hematologic origin will later speak also in my field. Atherosclerosis has a crucial point, atheroma, which is full of foamy cells, which are derivatives of macrophages. You can see the problems with macrophages in glioma in the brain, and perhaps these fields will be later, but not so late, also inspired by the movement which happened in the field which will be introduced now by Marek Trneny. Once again, welcome here, and once again, thank you very much, Marek.
Thank you very much for introduction. I have got the task to speak about the hematology advances, but I have not feel competent to cover it, so I have decided to invite world-known speakers who are members of the learned societies and who are really lead in their field. And I would like introduce first of all Professor Elias Campo, who is the director of the research of the Barcelona hospital, director of the research institute in Barcelona. He used to serve as a lead author of the WHO classification of the lymphoproliferative and myeloid disorders, and he has been a president of the Hematopathology Society, and finally he is the member of Catalunya Royal Society, and just recently has been elected as a member of the American Academy US Academy of Scientists. Elias, it's a really great pleasure that you have agreed to come just for a short visit, and we are looking for your lecture.
Thank you very much, Marek, for the kind introduction. I want to thank all of you. It's a great honor to come to this country, to this academy, and to share our thoughts and discussions on this challenging area of science of medicine. I would like to introduce to you how our way to recognize the diseases, mainly neoplastic diseases in hematology, have been and are changing thanks to the elucidation of the human genome, the human sequence of the DNA, because it's really changing the way we approach the diagnosis and the treatment of these diseases. Hematological neoplasms are originated in cells of the blood in two big groups. One, the lymphoid cells, that are the cells in charge of protecting our body against foreign insults, and the myeloid cells, also originated in the bone marrow. They are not very frequent, the lymphomas, but I think the importance of these tumors rise in different aspects. One is in the last decades of the last century, we saw a dramatic increase in the incidence of these diseases in all countries in the world. And that was mainly due to the infection by the HIV virus that generated an increase in the proliferation and neoplastic transformation of these lymphoid cells. But as you see, the distribution in the world of these diseases is very variable due to many factors. And right now, probably, we are in a steady state presence of these lymphomas. But what I think is very good news is that in all the countries, although the incidence increased dramatically, we are seeing that the mortality in these lymphomas, in these neoplasias, are decreasing, as you can see here. And that is due because of the tremendous improvement of the therapy that we are using in this neoplasm, and Dr. Trneny will explain later in more detail. And as an example, one of the tumors that we work more on in collaboration also with colleagues here in this country, we are seeing in this lymphoma, was considered one of the more aggressive. As you can see here, decade after decade, the proportion of patients that survive more than 4 or 5 years is increasing dramatically, and again, thanks to the new therapies. But the importance of these therapies make one aspect that is the correct diagnosis of this disease very important. Because each disease, each patient will require a specific treatment. And the spectrum of therapies for these diseases is very broad. There are patients that do not need treatment for many years because the disease is very indolent, and the patient can live with their diseases with no need of therapy. On the contrary, there are others that are tremendously aggressive, and if we don't treat the patient can die in just weeks. So to establish in which side of the spectrum your specific patient is extremely important, and that is the diagnosis. On the other hand, we have neoplasias of these that are curable with the current therapies, but we need to give the right therapy. So again, the diagnosis is very important. On the other side, some of these therapies are iatrogenic. They can cause also some damage to the patient. So it's important to balance the benefit and the potential damage. And again, diagnosis is extremely important to know the disease. And the diagnosis of these diseases is not easy. Just lymphomas, neoplasias originated in the lymphoid system, in the cells that protect us against foreign aspects, as you can see here in one of these classifications that we are used, are more than 70 different subtypes, each one with peculiar biology, peculiar presentations clinically, and each one requiring the specific diagnosis, specific treatments. So traditionally, we pathologists have relied on a very simple tool, that is the microscope, the sections of the tissue of the biopsy, looking at the cells. And as you can see here, and this has been tremendously important, because we have identified most of these diseases just based with these very simple and humble techniques, by looking at the microscope of sections of tissues in which we could distinguish two aspects: the architecture, how the cells are organized. As you can see here, the cells are organized in what we call nodules, so round structures. And the other aspect is the aspect of the cells under the microscope, and those are the nuclei, and you see these nuclei are irregular, and also here. So these two tumors look very similar. However, they correspond to two different, very different diseases. One, what we call follicular lymphoma. The median survival of these patients is around 10 years. The other side is what we call mantle cell lymphoma. The survival of these patients is only 3 years. So, and each of these tumors of these patients require different treatment. So establish which one is the diagnosis is extremely important. And for many years, we have only used morphology. However, the more and more we have been learning about the biology of these tumors, we have been applying different techniques along the years in the last century, starting with just using chemistry reactions in the tissue. When the immunological and antibodies become more and more available, we started to use immunological techniques to recognize different cell populations. In the 90s, when molecular biology allowed us to study more friendly the DNA and the RNA, we started to apply molecular techniques to understand some aspects of these neoplasias. But what I want to emphasize today is the revolution that has brought the elucidation of the human genome, the capacity of reading the sequence of the DNA of our cells, and how that is transforming our way we are recognizing these diseases. And that the big hit of that was the publication of the first human genome. That was in 2004. And that, just to give you a perspective, to sequence the genome of one single individual human, in fact, were 4 that were merged, it took more than 10 years of work of many groups around the world, and the cost is difficult to estimate, but when you look, it cost these impressive figures. However, in 2008, a major revolution starts in this, because new techniques of reading, the sequencing the DNA, reading the sequence of the letters of our DNA, was performed in Dr. Watson, one of the discoverers of the structure of the DNA, and also in 2008, individuals of the Han and Yoruba ethnias, and the first disease, the first cancer, an acute myeloid leukemia, were sequenced. That means that the DNA of these individuals and the DNA of this leukemia were sequenced, and the cost, as you see, were already 1,250,000. And the time to sequence that were 2 months. With this revolution in the techniques, there were some international efforts to understand the sequence, the alterations in our DNA in different types of cancer, because we knew that cancer was a disease caused by the alteration in the DNA of the cells. So there were a tremendous effort, the International Cancer Genome Consortium, that we from Spain participate, sequencing the DNA, the genome of the chronic lymphocytic leukemia. And you see how in these years already the price to sequence one patient went down, and the time to sequence was down to weeks. And nowadays, to sequence the genome of a patient could go down to a couple of few hundreds euros, and just in days. Interpretation is another issue. It could perhaps cost more time. But as you see how the revolution in the technology has allowed to incorporate these techniques in our daily practice. And that's what we call the first map that we got in the genomes of the acute leukemia. And this figure, that is this theater, each line is a mutation in one gene, and each line from a vertical line is one patient. And here we have the first 500 patients in which we sequence the DNA of the disease. And you can see here patients that have many, many alterations. The course of this disease was very rapid. And on the contrary, we have here a group of patients that was very intriguing, because in spite of having sequenced the whole DNA of these patients, at this time we have not been able to call one single gene as responsible for this disease, indicating that in spite that we have sequenced 500 patients, something was missing. We still didn't have the whole picture of this disease. That's what we joined forces with other groups in the world, particularly in the US, and we resequence and reinterpret with new informatic tools to read the DNA more than 1,000 patients with this leukemia. And now we even discover many more genes that were altered, even in patients that were only present in 1–2% of the patients. But now virtually all the patients we have found some alterations in the DNA. But now the clinical questions come. What does it mean to have patients with mutations in only 1% of the patients, 2% of the patients? How we are going to deal with this in the clinical practice? And still, those are questions that are not answered, and we are working on that. But sequence the whole genome is a tremendous effort, in spite that now is affordable in terms of economical interpretation and logistics. To incorporate that in our routine clinical practice is challenging. This means to sequence more than 3,000 million of letters of the nucleotides that form the DNA. Yes, we can get all the alterations, but the interpretation, as I mentioned, in the clinics is difficult. So that's why still we do not use the whole genome. A closer approximation is what we call whole exome. Whole exome means to sequence the part of the DNA that translate into proteins, that we know better what could be the function of that. That is less expensive, is more rapid, but still also challenging in terms of how interpret. And the practice, what we are doing now in the clinical, is to select the genes that we know may play a role in the disease, and that means for each disease around 100, 200, perhaps 300 genes, and that we get information that is more clinically relevant, and we can apply that to take decisions in terms of how to treat or manage the patients. But now we are under another revolution that still is not in the clinical practice, but I think is changing our conceptual view of these diseases, and we can envision that will be close to the practice in the future. Let me use these images. What we have been doing now to sequence the DNA is to take a biopsy, take a tissue involved by the patient, or take the whole blood, and we mix and destroy all the cells together to extract the DNA. And what we have is a pool of DNA, of RNA, of the whole tumor. That means millions of cells all together. Now, we have techniques that allow us to separate each individual cell of this tumor and study the DNA and the RNA of one single cell. So now we are passing from a global view to individual points of the tumors that are in the individual cells, with the hope that by having this puntillism of the tumor, we will be able to capture the heterogeneity and more precise aspects of the biology of these tumors. And I want to give you some examples of how we are doing that. This is what we are doing. We are separating the cells of the tumor by techniques of cell sorting. We are able to separate hundreds of cells of the tumors thousands of cells individually. In each cell now, we are able to read the DNA of a single cell, the whole DNA, the 3,000 millions of letters of this DNA. We can see the alterations, as you can see here, in just one cell. We can look and identify changes of letters. In these 3,000 million letters, we can see the changes, the A by C. We can also read the what we call the RNA, the transcription of this DNA. So just all this information from a single cell. But in each tumor, now we are able to do that in hundreds of cells, thousands of cells at the same time. And let me tell you some of the things that we are already learning. This is a patient from a chronic lymphocytic leukemia. This is the most common leukemia in our countries, in the Western countries. We had the idea that these tumors are originated in one cell, and this cell grows and grows, divides, multiplies. The surprise with this technique of single cell has been in 15%, 20% of the patients. The surprise is that initially we have diagnosed as having chronic lymphocytic leukemia. By doing the single cell analysis of these cells, the surprise has been that the patient does not have one tumor expanding. They have in these patients up to 6 different clones, different tumors that are originating at the moment of the diagnosis. Not only one, 6 that are expanding, that here we have painted in different colors. And how we know that all these tumors are not reactive cells that are expanding? We know because each cell has a barcode, if you want, that can identify it as specifically being all the cells come from the same origin. Is what we call the immunoglobulin receptor that is specific of each cell. So by reading the sequence of this particular part of the genome, we know that these 6 cells, these 6 groups of cells are all derived from one single. And now the question is, are all of them leukemia? Are all of them the tumor that the patient has? And as we can read what we call the RNA, we see that this is the normal B cells, and those are genes that are expressed in these cells. And you can see that the 6 different clones that we have here have some genes that are not in the normal cells, and on the contrary, some of the genes that are in the normal cells are not present in these cells, confirming that this patient does have simultaneously the expansion of these 6 tumors at the same time. With the current techniques, we thought that they had only one. So we are starting to see the complexity of these diseases. And another example, and with this is the last, but I think it's very intriguing, is that we had sequenced the whole genome of these patients with chronic lymphocytic leukemia that have evolved during 19 years. And we have the sample at the beginning, and we have the sample at the end of his study when the patient died. By looking at reading the sequence of the DNA at these different time points, we have been able to identify different, what we call clones, the same tumor, but they are diversifying in different groups of cells that are growing at different rapid evolution, or different evolutions. What we can see here, and we painted the different groups of cells in different colors, indicating that they derive from the same cell and they evolve in a different way. Look at this cell, the brown color. This is the expansion of the tumor that killed the patient, and appeared 19 years after we diagnosed this patient in the clinics. But when we look at the sequence of this, it was predicted that these cells were already present 19 years before the diagnosis. But also these 2 colors, the green and the pale pink, that relapsed the patient after one treatment, were also present at the moment of diagnosis. That tells us that at the moment of diagnosis, this patient already had all the cells that will dictate the evolution of the disease after the treatments and eventually will kill the patient. But that was a prediction of informatic analysis of the whole genome sequence. And I wanted to know if we could see these alterations in reality. And what we kept cells of these patients in our freezers in the hospital from the beginning 19 years ago and in periods in between. And we were able now to sequence specifically the cells that were at the beginning and all this period of time. And you can see here that a mutation in a gene that we know well, P53, in these two colors, that were present in virtually all the cells that killed the patients, were already present 19 years in less than 1% and 0.1% of the cells at the beginning, confirming that this patient had the cells that killed them 19 years before. And also we confirmed by looking at the RNA of the cells. That is the cells at the final moment of the diagnosis. You see these pink cells were the ones that unfortunately killed the patient. And we look at the transcriptome, at the RNA of these cells in all the samples that we have in between, including 19 years before. And you see we also detected these cells, indicating that the history of the cells could be already present in the moment that we diagnose the patients. And now finally, now we're able to construct what we call the phylogeny of the tumors. That means where the cells are coming and what are the mothers and the daughters of the cells. And just briefly look at this. If we have 3 cells that have the same mutation, that means that 3 cells come from the same origin. But if we see 2 cells that have a different mutations than the other one, means that these 2 come from a different mother than this one. And eventually, these cells might acquire different mutations, indicating that they have been diversifying in the evolution of the disease. And with this information, we can draw these phylogenies, like it was a family in which we could trace which was the father and which was, well, in this case, the mother. And also more important is that we know now that in our genome is acquiring mutations at a constant time during our life. We know that there are some types of mutations that are acquired every year, at a number of mutations per year. So now, if we count the mutations that have been acquired in all these, we can predict when these cells started to diversify, when they originate. So when we apply these techniques in these patients with chronic lymphocytic leukemia, like these patients that I mentioned you with 19 years of evolution, we have now drawn this map, this phylogeny, like a family tree, in which we know in which moment the patient acquires certain mutations. But just let me tell you that when this event that unfortunately killed the patient when he was 80 years old, the cells that have killed him, they were already present when he was 60. That actually was when I told you before that have diagnosed the disease. So we have confirmed in a different way that these cells that killed the patients were already present when 20 years before. But what is more intriguing is that now we could predict that the disease was already present when the patient was 30 years old. Although we only diagnosed the disease when the patient was 60 years old, we now predict that this cell was already there when he was 30. But then, just to conclude, I have been trying to show you how these new techniques of reading the genome of the cells are helping us to make more precise diagnosis. We are establishing the risk of the patient to evolve. We might have information to decide which treatments are better, and then we can monitor the disease. And now we are starting to see alterations that, if we understand better these alterations, we might be able to anticipate treatments of these patients many years before these treatments might complicate the life of our patients. Thank you very much for your attention. This is our academy in Barcelona.
Thank you so much, Professor Campo. In the interest of the time, we will have the discussion, the panel discussion at the end, but if somebody has a burning question which is directed to this lecture, so please do not hesitate to ask. Yeah? Do we?
Do you also use like epigenetic sequencing, like the changes in DNA methylation, not just changes in the sequence?
We have studied all these evolutions also at the epigenetic level, looking at the methylation, global methylation, but also some histone marks and some marks to see the regulation. But still, we are not able to do it at the single cell level. We are working on that, but there are some approaches, but still we have not managed this.
Any other question? Okay, so please think about your questions to the end. Elias, thank you so much. I have been asked to give the overview of the treatment evolution and the outcome of the biggest subgroup of the hematologic malignancies, which are lymphomas. This is my disclosures. And I would like to start with some epidemiology data from the Czech Republic. So these data represent the incidence, mortality and prevalence of the hematologic malignancies over last almost 30 years. And you can see that there is still increasing the incidence. The mortality rate is somewhat similar, slight increase, and the prevalence is significantly increased since the year 1994. The majority of those cases are the lymphomas or lymphoproliferative disorders. And on this cartoon, you can see that the incidence doubled within 30 years. It's 100%, it means more than 20% mortality rate, but the prevalence is 4 times higher than in the 30 years ago. So in the 1994, there were approximately 10,000 living persons with hematologic malignancies in the Czech Republic, and currently is more than 40,000. And what are the reasons? And I would like just to go with you over the history of the treatment of the malignancies. Around the 1900, the radiotherapy has been started, but one important point was the discovery of different chemotherapeutic agents. And almost all agents we are using until now have been discovered in the 60s. And just as curiosity, one example, our colleagues in German Democratic Republic in the 60s, they developed the bendamustine. The bendamustine was developed, synthesized because of the cyclophosphamide, which was developed in the Western countries, were expensive and not available here. And the bendamustine significantly changed and plays still the very important role in the treatment of the hematologic malignancies. The second revolution was the combination of the chemotherapy. And the combination of the different chemotherapeutic drugs in the 70s significantly has changed specifically Hodgkin's lymphoma. The Hodgkin's lymphoma was described as a lymphoma almost 200 years ago by Thomas Hodgkin, so this is why we call the Hodgkin's and non-Hodgkin's lymphoma. And he described a series of the patients with large lymph nodes in the Guy's Hospital. And when the specimens were examined by modern patterns some years ago, the majority of the cases were either non-Hodgkin's or Hodgkin's lymphomas. And this is the case of the combination of the therapy. And the Hodgkin's lymphoma in the 70s have been the first cancer which can be cured with a combination of the therapy. You can see all the patients are advanced stage, and you can see that more than 50% of the patients can be cured. But there is the price the patient has paid for, and because the high curability rate and the young age at the diagnosis, you can see the mortality for long-term follow cohort of the patients. The green line represents the cause of death of Hodgkin's lymphoma, and expanding or going up the brown line are the deaths from other causes. And the majority of the cause is the secondary malignancies, some other causes, the cardiac diseases. So what we can do for the patients to cure them, but just to spare their life. And then we can go and we can follow what Elias has described. So it means we can try to understand the biology of the lymphoma cells and just to use the therapy which is targeted to the several pathways. And then there is the other approach which we can call as a very simplified name, agnostic. So it means we do not care what the lymphoma cells is, but we take care about some other issues like the immune system. Because the immune system, or the majority of the tumors and lymphoma specifically, are trying to escape for the immune control. They hide their antigens, they suppress the immune system, and this is the major problem of the cancers. And you can see here that already in the 19th, Paul Ehrlich gave a talk in London on immunity with special reference to the cell life, and he described how the different substances can attack the different cells. And we are coming to the 70s, and one really big discovery was made by the Köhler and Milstein in the 75. They published so-called hybridomas. So what it is? So they challenge the mouse with the antigen. They use the spleen cells and they fuse them with the immortal myeloma cells, which were unable to produce the antibody, and at the end they were able to produce the monoclonal antibodies. And it has changed not only diagnostic but the therapeutic approach as well. And already in the 1979 the first patients have been treated with a monoclonal antibody. We do not know what was the target of this monoclonal antibody, and 10 years later, or more than 10 years later, those colleagues were a bit doubtful how to proceed further. But in the 90s, in the late 90s, the rituximab, which is the anti-CD20 antibody, has been introduced to the treatment of the B-cell malignancies, especially lymphomas, and it significantly changed the outcome of the patient. So it's engineered antibodies, and you can see that they can directly kill, but they can activate antibody-dependent cytotoxic cells. They can activate the complement, which finally leads to the cell death. And this is the data from the Czech Republic. You can see that when we use the combination of the immunotherapy, it means the rituximab plus chemotherapy versus historically treated patients, we have observed that we have been able to reduce the risk of death by 45% of the patients. So it means this is the reason, one of the reasons why prevalence is going up, and because we are able to cure the patients. I'm coming back from this agnostic approach to the targeted approach, and there have been a lot of the drugs which are tested, and they are already approved and used in these antibodies. I would like just to recall recall the thalidomide, the lenalidomide. You probably all know the story of the thalidomide, which was used as the sedativum, but it could be, then it was discovered that it caused the micromelia because of anti-angiogenic effect, which finally was found that it's because of it targets the cereblon. The Francis Kaysen was awarded by the John Fitzgerald Kennedy because in the 60s he was significantly against and he stopped to use thalidomide in the United States. So it means the micromelia was everywhere, not in the United States. But what has been found, it could be used as an anti-angiogenic effect, and it's widely used, these sort of drugs, in multiple myeloma, and I'm showing some examples of the mantle cell lymphoma, follicular lymphoma, and we still use this drug, and we can cure significantly more patients versus the other approaches. The other targeted therapy is the therapy which targets some targets which are connected with a B-cell receptor, which is vitally important for survival and proliferation of the B-cells. And one example is Bruton tyrosinase kinase, and we have several drugs currently which can be used, and it significantly improves the outcome, for instance, the chronic lymphocytic leukemia, the mantle cell lymphoma. So this is one study we have be part of the European consortium in the newly diagnosed young poor risk patient with multi-cell lymphoma. And this is just the example how the field is rapidly developed. This is the data from my department, CLL, and you can see that in the year 2021, 84 patients in the first line have been treated with the immunochemotherapy. 2 years later, only 7%, and 93% of the patients have been treated already with the targeted therapy like the ibrutinib and some other drugs. And we come to the other group of the drugs which are connected with the immune system. I have already mentioned that the immune system is suppressed by the tumor, and there is a lot of the approaches. One is what we call CAR T-cell. CAR, this acronym means the chimeric antigen receptor. T, lymphocytes, T-cell. What does it mean? We know that the T-cell recognizes the targeted antigen by the T-cell receptor. We know that the recognition is not so perfect. We know that for activation of the T-cell, not only recognizing the antigen is important, by the co-stimulation of the T-cell is important. And the tumor try to suppress this co-stimulation and this stimulation. So the chimeric antigen receptor represents an approach that this receptor is formed by the transcription of the DNA, which is transduced to the patient's T lymphocytes. Then the genetic modification made, the chimeric antigen receptor is expressed on the surface of the cells. Then the cells are expanded, and finally they are infused to the patient. They are able to recognize, and this is because of the antigen binding receptor, and we use in the majority of the cases anti-CD19, which is the B-cell antigen. It's a very good recognition. And then there is the co-stimulation part and the effector part. So it means that the activation of the cell is significantly simple compared to the normal physiological approach. and we use the second generation. This approach significantly changed the outcome of the poor risk patients who failed the classical immunochemotherapy, diffuse large B-cell lymphomas, mantle cell lymphoma, follicular lymphoma, and it really represents a very important step forward. The other approach is to use the bispecific antibody. I have mentioned the CD20 antibody. So on the both FAB fragments, so they are targeted to the CD20. In this situation, there is one arm targets, one binding site targets the CD20. In this case, it could be CD19, it could be different, and the other CD3. So it means the antigen which is recognized, which is present on the T cell, and it led to the activation of the T cell, and it leads to the tumor cell killing. So this approach is currently under testing. We have already in the Czech Republic one bispecific approved and reimbursed. Others are approved but not reimbursed yet, and we are participating in the several studies or are involved in those research. And finally, I would like to mention immune checkpoints. So the immune system, from the physiological point of view, has to have some control. If we meet with some infection or whatever, the immune system is activated, but definitely it needs to be controlled. Overactivations will lead to the autoimmune problems, etc. The tumor uses these immune checkpoints just to suppress immune system. The antibody, which are the monoclonal antibodies, which are called immune checkpoint inhibitors, just to allow to activate the immune system to overcome the suppressor effect of the cancer, and finally the immune system is reactivated and could kill the tumor. Definitely, for instance, the adverse events, because everything has some adverse events, are different compared to the classical immunochemotherapy, because the majority of the adverse events resemble the autoimmune diseases, autoimmune symptoms. And you can see on this table that there is a lot of the tumor, and it has significantly changed solid oncology, but the Hodgkin's lymphoma has significantly best response rate to the immune checkpoint inhibitors. This is because of some genetic findings on the short arm of the 9th chromosome. And for the research in these, the two guys, James Ellison and Tasuku Honjo, have been awarded by the Nobel Prize a couple of years ago. And finally, I'm coming to the monoclonal antibodies, which are not exploring the immune systems, but which are using as, let's say, the key which can find the specific antigen, and they have the cytotoxic drugs binded to them. So at the end, if, for instance, this is the case of the polatuzumab vedotin, which is the anti-CD79B antibody, the majority of the B-cell lymphomas have this antigen. The antibody drug conjugate is internalized in the lysosome. The cytotoxic drug is cleaved and released, and it leads to the microtubule disruption. So there is a different drugs which are using, but this is, for instance, this combination this drug has been the first approved drug after 20 years in the first line treatment. And I would like just to show you how all those changes change the outcome of the whole population of the patients with diffuse large B-cell lymphoma, which needed the third-line therapy. So it means those patients who failed two-line therapy. The first column in both arms represent the patients treated in the 2018 till 2020. The second column represent the patients treated 2021 till the half of the year 2023. So it means they are all patients, not patients only who have been treated with some specific drug, all patients, and you can see that it's significantly by the 35% reduces the risk of death or progression for those patients. So it means within the short period of time we are showing that we can able here in the Czech Republic to significantly improve the outcome. So why we are so successful? As I showed you, we are targeting the lymphoma cells not only by the lymphodepletion, so it means just the chemotherapy and the radiotherapy, but we are using the targeted chemotherapy like the antibody drug conjugates. We are using the directed therapy to the different pathways. And finally, we are using the drugs which are going to activate the immune system and overcome the cancer immunosuppression role. So thank you so much, and I will be happy to discuss any question. If there is some burning question, okay. If not, I would like to introduce Professor Jan Trka. Professor Jan Trka is the leading person in the field of the lymphoid malignancies research. He is founder of the CLIP, which is the laboratory in the Motol, which is world-known, recognized. He is a leading person of the several studies. And he has been awarded by the EHA several times, and I'm really very happy that he has accepted our invitation.
Thank you, Marek, both for the invitation and the kind introduction. I'm indeed from the Motol University Hospital and the Second Faculty of Medicine, and I represent here a group known informally as CLIP, which stands for Childhood Leukemia Investigation Prague. And I will be talking today about biology and therapy of childhood acute lymphoblastic leukemia, which I'll be referring to as ALL throughout my talk. Okay, so let's start with the biology of ALL. So how does acute lymphoblastic leukemia originate? We all carry in our cells, of all the cells of our bodies, some genetic background. So it's the same for hematopoietic cells. And when one of these cells is struck by something we can define as a genetic hit, which typically for ALL is either chromosomal translocation or change of the ploidy, it gives origin to something what we call pre-leukemic clone. It's not a definitive leukemia, it's just pre-leukemia, and this clone has some proliferative long-term advantage that helps it to survive under the selection pressure. Then one of the cells of this pre-leukemic clone is hit by a second event, which is something typical for other tumors like mutation, deletion, or insertion. And this gives the clone the definitive proliferative advantage. It starts to grow rapidly, and that's the moment we diagnose acute lymphoblastic leukemia. What's interesting about this natural history of this disease is the fact that the first event, the first hit, usually happens during the prenatal life of the future patient. So how do we know that? We first learned that from the identical or concordant leukemias in monozygotic twins. They were reported already in late 19th century, and in early 90s, a group of Malgreaves in London for the first time analyzed genetically 3 cases of concordant leukemias in 3 pairs of monozygotic twins. And they found out that these leukemias were within the pairs completely genetically identical, and it was not caused by inheritance, and it was not caused by chance. And we know now that the pre-leukemic clone originates in the body of one of the twins and then the cells travel through the placental anastomosis to the second twin, where they find a completely identical environment, in fact metastasites, and so both of the twins are born with the presence of the pre-leukemic clone. Is it something rare, or is it a normal event? It was difficult to learn that, because for the typical case of leukemia, we first meet our patient at the time of diagnosis. So the events preceding the onset of the disease are hidden to us. However, we have sometimes access to the material that allows us to backtrack the pre-leukemic clone to the time of birth or to the perinatal period. It's either Guthrie card, which is dried droplet of blood that are used for genetic screening for the metabolic diseases and are stored for forensic reasons at least in some countries, or it's cord blood that's stored for some newborns, and it can be analyzed later. We and others have analyzed Guthrie cards for the presence of the pre-leukemic clone using several different markers, and we indeed shown that the pre-leukemic clone was already present at the time of birth in these children, and the same was proved by us and others in the cord blood stored for the future leukemia patients. So, how frequent is the prenatal origin of leukemia? We and others have focused on the fusion gene ETV6 RUNX1 originating from the translocation 1221. Why? Because it's the most frequent genetic aberration in pediatric ALL. So we analyzed hundreds of stored cord bloods of healthy newborns, and we indeed found in a significant proportion of them the presence of ETV6 RUNX1 positive cells, and it was later confirmed by a larger study that used a different approach. Why the differences in the frequency of the pre-leukemic clones? It clearly depends on the method used, because it depends on the sensitivity. Negativity, that does not mean that the leukemic clone is not present there. So we now know for sure that the emergence of a pre-leukemic clone is very common. On the other hand, already from these numbers, we know that the pre-leukemic clone is a lot more frequent than the definitive leukemia, at least for 2 orders of magnitude. So what about the second hit? When does the definitive, the full-blown leukemia originates? On this graph, you see the number of cases diagnosed at each age group. And you can clearly see that the majority of children are being diagnosed in the preschool age, aged from 2 to 5 years. So what's typical for what we know about this age? We know that in the previous period of life, from birth to 1 year of age, in the past, children faced typically very severe infections. We have, by introducing high hygiene standards and vaccination, we removed the threat from the very early age. And we believe that the immune system now lacks the antigenic stimuli that would modulate this. And the alteration of immune signaling leads to dysregulation of immune response in this preschool age to benign infections children meet during their socialization period in daycare or kindergarten. And this theory of dysregulation that leads to the second hit in the preleukemic clone is called delayed infection hypothesis and was formulated by Malgreaves in late 80s. And we have plenty of epidemiological evidence for that. I don't want to go to detail into that because I want to show you an interesting experimental model of delayed infection hypothesis. Spanish and German colleagues in Düsseldorf, in fact, they introduced a very interesting mice model of preleukemia. And they kept these mice carrying the preleukemic clone and wild-type mice in germ-free environment. And as you can see, none of these mice developed leukemia. However, when they move them to common infectious environment where the mice are normally kept, the wild-type mice remain healthy. However, in the group of mice that carry the preleukemic clone, there was a significant proportion of those that developed a disease very similar to pediatric acute lymphoblastic leukemia, even carrying very similar second genetic aberrations. So it's a nice mechanistic evidence for the delayed infection hypothesis. When you, as a doctor, deal with the family, with child with very severe disease, you always are asked a couple of questions like, did he or she inherit the disease from us, or did we do something wrong? So what about acute lymphoblastic leukemia? What about genetic background and risk factors? We obviously know some very rare genetic syndromes linked with ALL, like Hermine or ataxia telangiectasia. But these are just tip of the iceberg. They are very, very rare. But we know genetic variants or polymorphisms that minimally increase the risk of leukemia. We know now about 14 of them. Some of these polymorphisms are in genes that make sense to us because they are either involved in the immune response or are in the genes that are involved in lymphopoiesis. Some of the loci doesn't mean much to us at the moment, but definitely they will. But they really minimally increase the risk of leukemia, just 2 to 3-fold. So for an individual patient, it doesn't mean any increased risk, in fact. We don't know risk factors except for massive radiation, and thus we cannot prevent ALL in children. This leads us nicely to the second part of my talk, which is focused on the therapy of pediatric ALL. Although we all know that acute leukemias are the most frequent childhood malignancies, these diseases are in fact very rare. We only see about 80 newly diagnosed patients with pediatric ALL in the Czech Republic. Here you can see the survival curve and the development of treatment outcomes over the last, let's say, 60 years. And what you can see here is that although we don't have a complete data for this period, you can see that massive improvement of outcome between 80s and 90s. And if you look at the same curves from Western countries or US, just some decade before us, you would see the same picture. And you can see that every 5-6 years period, with every clinical trial, we are improving the prognosis, although it's going slower and slower in the recent years. So what was the reason? What happened between 80s and 90s in Czechia, or between late 60s and early 80s in the rest of the world? Was it new drugs? Not really, because vast majority of the drugs we use now for the combined intensive chemotherapy for children were already known in 50s. Stem cell transplantation is only for the patients with really high risk of relapse. So it's not the general mean of treatment. Surprisingly, the main difference was the intention to treat these children. until 60s, it was believed that ALL is simply incurable disease, and the intention to treat was only palliative. And the intention to treat actively with combined chemotherapy brought us the first initial success. And we still use the treatment schemes that were developed in 70s by US and German investigators. The scheme comes as intensive induction treatment, followed by consolidation, reinduction, and maintenance. Another important factor is the relapse prediction or risk stratification for patients for the choice of the right therapy, and obviously molecular genetics and immunology in recent decades. And the treatment would not be possible without very expensive supportive treatment, antibiotics, antimycotics, and virostatics. So this is the scheme of a typical treatment protocol as used in Czechia and in other countries all over the world. They are not completely identical, but very similar. For patients with high risk of relapse, we use a different scheme with more treatment blocks. And during the past decade, we started to introduce some new drugs, and I will get to that later. So, what defines now the prognosis of patients with ALL? I don't want to go into detail. I don't want to use gene names and translocation numbers, but just generally. We have learned that leukemic cells carry some genetic changes, translocations, ploidy changes, mutations, deletion, insertions. We can call it, in summary, a genotype. And empirically, we know that some of the genotypes of leukemic cells or these leukemias have excellent outcome, and we can treat these children with reduced therapy. Then we have the intermediate group of patients with about 80% survival on the standard therapy, and much smaller group of children with outcome about 60% or less, and these need intensive or alternative therapy. I just want to show you this to demonstrate that using the classical genetic approaches, we were able to genetically classify or characterize about 2/3 of patients by introducing genomic approaches like SNP array or next generation sequencing. We are able to provide more detailed genetic classification, and only about 7% of ALLs remain genetically unclassified. So, and the second factor that defines prognosis is the response to treatment. And again, it's very simple. If leukemia responds to treatment well, if there is fast elimination of leukemic cells, it's a good prognostic factor, and we can use reduced therapy. On the other hand, when the elimination of leukemic cells is slow and minimal residual disease is still detectable after several months of therapy, it's a bad prognostic marker, and these patients must be treated with intensive or alternative therapy. What approaches we use for MRD detection? At the moment, we have one universal marker already mentioned here, and it's immunoreceptor gene rearrangements that can be found in 98% of ALL cells, and we can detect MRD using these individual IGTR rearrangements using NGS and qPCR in combination with a sensitivity of one leukemic cell among 100,000 normal hematopoietic cells. We can use flow cytometry focused on the specific leukemia-specific antigen expression with slightly lower sensitivity, and lately we also use more and more fusion-specific qPCR on genomic DNA level, again with very high sensitivity. And if possible, we combine these approaches because they might provide us with a different information in the particular times of treatment. So overall risk prediction is now at the moment using only two factors. It's the genetic of the leukemic cell and the response to treatment. And based on the combination of these two factors, we divide patients into three categories. One with very low risk, almost no risk of relapse, the intermediate group with low risk of relapse, and a very small, less than 20% of patients with high risk of relapse. What's the diagnostic algorithm for the Czech pediatric national ALL study, just for the people in the audience who deal with similar diseases? We use immunophenotyping by flow cytometry for the initial diagnosis and for MRD detection at the beginning of the treatment. Then we use combination of classical genetic and genomic approaches to search for recurrent translocations and other well-known genetic aberrations. Then we perform detection of minimal residual disease at the end of intensive induction treatment by combination of NGS and quantitative PCR. And in the patients that are not genetically characterized by the previous approaches, we use transcriptome sequencing, and in a small minority, we use exome sequencing, particularly in patients when we search for predisposition. So what to do when treatment goes wrong? We have approximately 3% of leukemias that respond badly or not at all, and about 5% of leukemias that relapse very early during the intensive treatment, and it's a very bad sign. It means that the leukemia is truly resistant to the combination chemotherapy. What shall we do? In the past, we only had more intensive therapy or stem cell transplantation, but these patients are typically heavily pretreated, so more intensive therapy is not the option. In the last decade, we have novel approaches. Some of them were already mentioned here by the previous speakers. We use signaling pathway inhibitors like tyrosine kinase inhibitors for subgroups of patients, and bispecific antibodies and CAR T cells. So a couple of take-home messages. Childhood ALL is now a curable disease with overall survivor over 90%. Only genetics and response to therapy are now crucial for prognosis and choice of the intensity of treatment. And modern immunotherapy, bispecific antibodies and CAR T cells can save approximately half of patients with resistant, formerly incurable leukemias, and they decrease therapy burden for all children. And what are the ongoing challenges? Obviously is the treatment of the resistant leukemias and reducing treatment toxicity for all children. Thank you for your attention, and I'll be happy to entertain any question.
Thank you so much for great presentation, great overview. And if somebody has burning questions, we will come to the questions at the end. Okay, if not, then please reserve the questions. And finally, I would like to ask Professor Olivier Hermine, who is the head of the laboratory dealing with hematologic diseases and the therapeutic approaches in the Necker University and in the Descartes University and the Necker Hospital. He has been awarded many times, and he has been elected as a member of the French Academy of Sciences, member of the Belgian Royal Academy of Sciences, and Academy of Sciences Europe. Olivier, it's a great pleasure for us to welcome you, and we are now slightly moving the topic from the lymphoid malignancies to the hematopoietic questions.
Thank you very much. Can you hear me? Marek. So I will move from cancer, I should say, to red cells. And as you know, we, as hematologists, we forgot to work now anymore on red cells because we focus our work on malignancies. But every time I said, if we have no red cells, we cannot survive, because red cells is the only cells, if you can remove lymphocytes, macrophages, and so on, but if you remove red cells, there is no life. So I think red cells is a very important cells. And first I will come back to hematopoiesis, which is the process of making blood cells, which occur in the bone marrow from stem cells, as you can see here. And then upon some differentiation, these stem cells will split into myeloid progenitors and we call lymphoid progenitors. And then they will follow a maturation process to give rise to mature cells which circulate in the peripheral blood. And you can see this process is quite complex. And for example, you take the early erythroid progenitors here, when they go into the differentiation to give rise to mature red cells which are very peculiar because they have no nucleus anymore. It's only cells with no nucleus. And this process takes, at least 8 divisions. So what we can expect is from one cell here, if you have 8 divisions from one progenitor to come to give rise to one red cell, it takes 2 to the 8 cells from one cell. So it's a huge amplification system. And as a result, we have a lot of red cells in the peripheral blood. You can see with the peculiar shape, and this shape is very important. I will tell you why. And so, in our body, the red cells are more abundant cells. I mean, you have a lot of red cells, even more than bacteria in your gut. And very interestingly, these cells, we do make 2 × 10⁶ cells per second. So it's a massive proliferative system. I don't know any cancer proliferate more than the way to build a red cell. So it's the most massive proliferation system that we do know, and it's very important to understand how it is regulated, because we can make a lot of hypotheses to any kind of proliferation system, including cancer. And you see also these cells are quite small, 7 to 8 micrometer, is because they have to go everywhere in the body to provide oxygen in all tissues, which is very important. And also in physics and biophysical terms, they have this peculiar shape, like we call biconcave cells. And by this way, even if they do 7 micrometer diameter, they can go in the very small capillaries, which only 3 micrometers of diameter. So I think it's a very unique peculiarity of these red cells to have this shape, and the evolution makes these cells like this to go everywhere and to circulate very rapidly in the body, because they can circulate in 20 seconds in all parts in your body. So I think it's very important. And these cells, of course, they survive around 3 months, and they can store a lot of metabolite inside, and to keep them and provide them in different tissues. For example, vitamin C is stored in red cells. And interestingly, also, these cells need to remain very slippery at the exterior to prevent any thrombosis and any agglutination in some capillaries to prevent some stroke and ischemia, which is very important. And finally, 90% of the proteins in the red cells are hemoglobin. And hemoglobin is also a very important protein which takes a lot of modification during evolution to be able to capture oxygen in the lungs and then to release oxygen in the peripheral tissue. And so far we tried to make artificial hemoglobin, but nobody could be able to perform such evolutionary magnificent molecule to be able to store the oxygen and to release it. And it does that through the heme nucleus, which is very important within the hemoglobin and contains a lot of iron. And iron is critical for red cells because they do need iron to make hemoglobin to be able to transport oxygen. So erythropoiesis, the way to make red cells occur in the bone marrow, and what we call the niche in the bone marrow and in the blood island, a very peculiar system also in which you have a macrophage, which is on the middle, and here you have all of the progenitors and precursors of the red cells, because macrophages are able to provide iron for the red cells and also to take up the nucleus of these red cells when they finish their maturation. So these macrophages in the bone marrow are very important for the maturation of the red cells. Something also we have to understand, which is very important, because I told you we make 2 × 10⁶ red cells per second. And all life long, we have the same level of hemoglobin in the peripheral blood, meaning that we have to destroy also 10 2 × 10⁶ red cells per second. So there is a very fine coordination in the body, because to maintain all time in our lives the same level of hemoglobin while we are producing 2 × 10⁶ red cells per second. And if we have not enough red cells, we will have some hypoxia and we die by hypoxia. And if we have too much red cells, we will die by hyperviscosity and thrombosis. So I think you have to be very tight, and the body has to be able to adjust very rapidly the number of red cells we produce or you destroy to maintain the hemoglobin level at the same level. And to do so, we know in the bone marrow there is some components which are critical, but the most important component are what we call the cytokines, which are proteins which bind to some cells in the bone marrow to determine the fate of these cells. And there is three main events from these cells. They can either proliferate or stop to proliferate. They can survive or they can dead, or they can differentiate or no differentiate. And depending on these three systems, and depending on the cytokines, they may determine the fate of the red cells. So what we know to engage multipotent stem cells towards the erythroid differentiation, there is what we call a master gene of differentiation, which are proteins, which are transcriptional factors which bind to the DNA to engage a program of differentiation. And for erythroid cells, the master gene is what we call GATA1. It's a very important proteins. And then the cells will differentiate towards the production of mature red cells. And GATA1 open all genes which are very critical for the erythroid differentiation, including the globin genes, and we will see the EPO receptor. And the second thing which is very important is these cells, to survive, needs to receive a signaling pathway from a protein which is well known, which is erythropoietin. And erythropoietin, when it binds to its own receptor, induces some signaling pathway, which induces the proliferation and the survival of erythroid progenitors. And because they do express GATA1, they will differentiate, because EPO will determine if they proliferate and if they survive. So the model of regulation of erythropoiesis, which has been made 40 years ago now, shows that EPO is made by the kidney. And depending on the level of oxygen, the kidney will produce more EPO, and in the bone marrow it will target more progenitors, will survive and will proliferate and differentiate, because GATA1 can induce a program of differentiation. And then as a result, because you increase the level of oxygen in the peripheral blood, because you do increase the number of red cells, the kidney will feel that there is too much oxygen, and they will stop the production of EPO. And as a result, the cells in the bone marrow will die by apoptosis. And so on, you have less EPO, less oxygen, so the kidney will make more EPO. So you have a circle here in which you have a target organ, which is the bone marrow, in which you do make red cells, and you have an endocrine gland, which is a kidney, to make erythropoietin. So it's a very tight regulation system. And actually it takes 20 years, even 30 years, to understand by which mechanisms EPO, oxygen, may regulate the production of EPO. And it depends on the transcriptional factor, which calls the name is HEF, or epoxy-inducing factors, will lead to the Nobel Prize for these two finders of these transcriptional factors. And we know that with oxygen, this factor will be oxidized and will be destroyed by the proteasome system. So we can now rely the oxygen in the kidney to the expression of this transcriptional factor, which activate EPO. So when you have enough EPO, you differentiate. And in case of no EPO in the bone marrow, the cell will die by apoptosis. And what we have found is that during this apoptosis process, they activate enzyme, which called caspases, which has proteases, and one of the main functions of this caspase is to cleave some proteins in the body to induce the apoptosis and the death of the cells. But in erythropoiesis, which is very interesting, they induce the cleavage of GATA1. So if you have no GATA1, the cells will not differentiate anymore, and in addition will die by apoptosis. So you see here the system in which this enzyme, the caspase, will regulate the number of red cells that you can produce because they induce the death. And in addition, we know that in the bone marrow, depending on the niche where the cells are, if they have enough oxygen and glucose and iron, they can engage towards the erythroid differentiation, and then EPO will determine the level of EPO, how many cells they can still proliferate and survive. So in this system, we come back here, you can see the cells, they may differentiate when you have low EPO, low oxygen, so high EPO. They will differentiate to give rise to mature red cells, and they do express GATA1 along this differentiation process. In contrast, when you have no EPO, they will die by apoptosis here, and they will not differentiate because they cleave the GATA1 factor here. And this apoptosis is due to the depolarization of the mitochondria, which induces the program of caspase activation. But the system is not as simple as we were thinking before, because we are struck when we observe the differentiation and the maturation process of red cells. You can see here that the cells, they condensate their nuclei, and they condensate their chromatin, and the nuclei become very short, very small, and by this way it can be extruded from the cells, giving rise to the red cells. But when you do observe cells which are dying by apoptosis, we say the program cell death, they exhibit exactly the same features. I mean, they do concentrate their nucleus, and they do condensate the chromatin. So we made the hypothesis that during this differentiation process, caspases, which are responsible for cell death, might be also critical for the differentiation to explain this process. And in fact, we show that during differentiation, this enzyme, which kills the cells, are also expressed and transiently during the differentiation. But very interestingly and surprisingly, we found that the GATA1 transcriptional factor is not cleaved. I mean, the cells, they can still differentiate, and the caspase will cleave a lot of targets, which explains the condensation of the nucleus and the extrusion of the nucleus. But they do not stop the differentiation because GATA1 is still expressed and is not cleaved during the differentiation. So we came to the next question to explain by which mechanisms GATA1 is protected. So we came with this model in which you see the cells, when they start their differentiation, they will activate the caspases. And depending on the level of EPO, they will go to death or they will go to differentiation. Not because the caspases are activated or not activated, because they are activated, but downstream the caspase activation, there is a very tight regulation system to protect or induce differentiation. And to make a long story short, we conclude at this level that the caspase-free is critical both for differentiation and apoptosis. And in other terms, if we want to block cell death, like in all body, I should say, we cannot survive and differentiate. So if you want to differentiate, you have to die. So I think it's very important for the system of erythropoiesis. So the question is how GATA1 is protected during caspase activation. And to make a long story short, we found that during differentiation, there is what we call a heat shock protein, which usually is able to fold the protein which has been totally disorganized because of the heat. And we found that during erythropoiesis, one of them, which is called HSP70, is highly expressed during erythroid differentiation. And this protein goes to the nucleus to protect GATA1 against the cleavage by caspase-free. But when you remove EPO, this protein goes outside the nucleus. So what we found here, we found that the fate between death and survival depends on the localization of HSP70. If it is in the nucleus, you go to differentiation. If it goes outside the nucleus, you go to dead. So I think it's very important because you can choose very rapidly if the cell will produce red cells or they will die by apoptosis. So in this system, so you see it's quite complex, but it's very tightly regulated to allow the cells to decide in the body if we make red cells to allow the good oxygenation, or otherwise to kill the cells if we make too many red cells. So you see, in this system we have critical actors, which are the GATA1 factors here, which induce the differentiation, and the hypo receptor, which allows the proliferation and the differentiation of the cells. And this system might be disturbed by a lot of disease involving erythroid cells disorders. So we can envision the disease of red cells, either first, because in some cases we know that there is a skewing towards the myeloid lineages, and the cells, instead of going to the erythroid lineage, they go to the myeloid lineage. There's a competition at this level between the two lineages. And then, why they are engaged in one process, in healthy erythropoiesis, you see an amplification of the precursor during the differentiation to give rise to normal red cells, but sometimes what we call defective erythropoiesis, because you have no proliferation here, or the cell died before the end of the differentiation. And what is very interesting also, in some disease we call ineffective erythropoiesis, meaning that the cells engage towards the erythroid differentiation, they proliferate very nicely, but at the end of the maturation they die in the bone marrow before they can give rise to a normal red cell. So you can see we can defect, in which we can say defective erythropoiesis or ineffective erythropoiesis. And you will see it's very important to understand why these mechanisms are totally different. And one of the diseases, which is a model of ineffective erythropoiesis, is beta thalassemia. Beta thalassemia is one of the most important genetic diseases in the Mediterranean area and in Southeast Asia and in part of Africa. And beta thalassemia is characterized by the lack of beta chains of the globin, which result in an excess of alpha chains. And these alpha chains will induce aggregates within the erythroid cells, and we know this aggregate because they bind heme, they will release some iron, which by the Fenton reaction will induce reactive oxygen species, which are quite toxic for erythroid progenitors. But what we found in these patients is that the erythroid differentiation show ineffective erythropoiesis with a high increase of early progenitor and the death of end-stage erythroid maturation. And as a result, you see this patient exhibit a lot of bone abnormalities because the cells, they proliferate in the bone marrow too much. They have no more control, like a tumor, I should say, and you see the bones get some deformation. And sometimes you see also these erythroid progenitors, they proliferate too much, and they go outside the bone marrow, as you can see here, like a tumors, and sometimes they can compress and the spine, and the patient can get paralyzed because they have too much erythroid proliferation. And a second consequence of this ineffective erythropoiesis is the fact that the erythroid cells, they are not only cells to carry hemoglobin and oxygen, but also they produce some factors, like for example erythroferron, which induce in the liver the repression of hepcidin, which controls the iron absorption in the body. And in this case, the patient will absorb a lot of iron, which is going to all tissues to induce some reactive oxygen species and kill the tissue. And this patient died of cardiac insufficiency and liver cirrhosis and so on at the age of 30 years because of the erythroid and iron overload. And second of all, the cells that can go through the differentiation are not normal, and you see red cells with a lot of aggregate, which is going to occlude the vessels of the patient and induce some ischemia in the periphery. So the question is, what is the mechanism by which the cell died before they can go outside the bone marrow? And we found that the HSP70 protein, instead to go to the nucleus to protect GATA1, is sequestrated in the cytosol where you have an excess of alpha chains. Because these alpha chains are toxic, and HSP70 is going to chaperone these chains to prevent the cell death. But by doing so, GATA1, you can see disappear, you can see here, during the differentiation, and the cells died. So what we can do here, we can prevent the HSP70 to go outside the nucleus by blocking the export of these proteins. There's a drug which is used in cancer, to block the export of the protein from the nucleus, which is here the synelexor, for example. And if you block HSP17 in the nucleus, the cells could differentiate again because you protect again GATA1 in this case. And the second things we found is try to understand why the reactive oxygen spaces here induce the proliferation of early erythroid progenitors. Here, too, to make a long story short, we found that the member of the TGF-beta family was highly expressed in these erythroid cells, both in mice and humans. And one of them is GDF11. And GDF11 is not very well known, but there is a lot of evidences showing that this cytokines is highly expressed in elderly patients and responsible for muscular atrophy, for cardiac insufficiency, and so on, what we do see in this patient. 5 minutes? Okay, I will finish rapidly. And interestingly, what we found, we make the hypothesis that if we do block these proteins with an antibody, which is called, the name is luspatercept here, we can block the signaling of this GDF11. And what we do find is that treating this patient improves significantly erythropoiesis, and these patients are not transfused from of them. Before they were transfused, but now they are not transfused anymore because we increase the hemoglobin. And very interestingly, this patient, because of the abnormal red cells, they suffer, for example, of leg ulcers, and you see this patient get cured very rapidly because GDF11 is responsible to the lack of cicatrization of this patient. So it was very interesting to see that if we do block these molecules, we increase hemoglobin level and we decrease the complication in the periphery, and probably also we will improve the cardiac function of this patient. And the second hemoglobin disease, which is very important, is sickle cell disease. And sickle cell disease, it's a very, the most genetic important disease in the world. And this disease is characterized not by the lack of hemoglobin, but abnormal hemoglobin with mutation in the beta chains, will precipitate in the red cells when you have hypoxia or when you have metabolic changes. And as a consequence, the cells will explode and you have hemolysis, but also they will induce thrombosis in small vessels, and these patients are suffering of ischemia and stroke and so on because of these abnormal red cells. And we found that these patients have also a defective and ineffective erythropoiesis, both because we know there is a skewing towards the myeloid lineages and the reduction of the differentiation towards the erythroid cells. And then we tried to explain this mechanism of action, and we found that the hemoglobin S, the mutation, activate what we call the toll receptor, inducing inflammation in stem cells. And we know this inflammation induces skewing toward the myeloid lineages, and the cells that generate from this skewing, the myeloid are abnormal and they are very inflammatory cells. And second of all, we found that they express also GDF11, and if we do block GDF11, we increase also, we increase the hemoglobin level, and we reduce, we can see here, the aggregation of red cells within the vessels here in the lung of these mice. So now we try to move this concept in clinical setting for the patient. And I will finish here. And we have seen here that with these two very important hemoglobinopathies, that the dysfunction of erythroid regulation may lead to some abnormal erythropoiesis, but also systemic disease involving all organs of the body. And we can target that. For example, by iron chelators, we can reduce the reactive oxygen species, which may induce the differentiation toward erythroid lineage instead of myeloid lineages. And if we do block the GDF11 here, we can restore the terminal erythroid differentiation and reduce the ineffective erythropoiesis. And this, and with 2 slides, and finish, promise, led also to a new concept of what we call clonal hematopoiesis. And we do see before, in patients during aging, we observe some, in the bone marrow, some mutation. And some of this mutation will provide an advantage of some clones. And by the age of 50 or 70, 20% of the population bear this abnormal, I should say, clonal hematopoiesis. And this clonal hematopoiesis, as I say here, increase during ages, reduce the production of red cells by ineffective erythropoiesis and defective erythropoiesis, and produce also abnormal myeloid cells which produce inflammatory cytokines. And these inflammatory cytokines are responsible of cardiovascular disease, atherosclerosis, as you can see here, in the same mechanisms that we did observe in sickle cell disease, which is very important because these inflammatory cytokines will induce stenosis of arteries in the periphery. And in addition, it has been shown that this abnormal myeloid differentiation and clonal hematopoiesis is responsible of a lot of disease of aging, including cirrhosis and lung cancer and chronic kidney disease, and also the evolution toward acute leukemia. So I will stop here because I have no time. And
thank you so much for a different overview. Olivier, if you can join us, and we have some time for the discussion, for questions. Please feel free to have any question which comes to your mind. If I can ask Elias, so I've been fascinating by your case with the 19 years examination with a different time point. At the end, the patients, if I understood well, developed what we call a Richter transformation. So it means very, very adverse event. So are we able to, or are you going in direction to be able to predict if this transformation could happen within 1 year or 2 years or after 20 years, or how these subclones will behave during the different treatment and during the time?
I think that's the intriguing questions that we are trying to address now. We have studied 20 patients with this, what we call this very aggressive transformation. Chronic lymphocytic leukemia is a very indolent disease. Normally the patient can live with this disease for many years, but unfortunately about 5 to 10% of the patients suffer this malignant transformation. What we have seen is that at least half of the patients, in 10-12% patients, that we have seen these clones that kill the patient already at the moment of diagnosis. The 19 years was the extreme, but we have seen these patients have taken from 8 years before they are there. The challenge now is how we can recognize this. We have some clues of some particularities of these cells that we can identify, but we are looking now if how specific they are. The question is, can we see these signatures in patients with CLL that we have followed for many years and we know that they have not transformed? Are we able to detect them? That's what we are studying now, is one of the aspects that we are studying, and still we don't know. And that's one of the questions. Can we detect these clones prospectively? And then what we will do? Those are the questions that we try to answer.
Thank you so much. Professor Leibel has a question.
Let me ask with this aspect actually. So I'm a mathematician. I'm not. I don't do medicine, but this aspect that you somehow see this single cell somehow being there a long time before actually it kills the patient. Does it indicate that actually this fact of this killer cell is a property of a single cell, or is there rather some process of a lot of cells which leads to the death?
I'm not sure you understand. You are asking if there is one cell initially, or they are...
Yeah, so if for a cell to become let's say, the deadly thing, or even singles. If basically my question is maybe more abstract, if the process of the disease is caused by a single cell, is really process of single cell, or if it is a process which involves a lot of cells?
I think, well, it's not easy to answer. My thoughts are in the way that is a combination of both. Initially, we know that these tumors originate in one cell. I already mentioned that some patients have many different single cells that are giving place to different tumors, but this is only at the beginning. Once one cell has started to expand, they give rise to different daughters cells that acquire some alterations by themselves. At the beginning, one of them predominates, and the others are like control, or they cannot survive as well, because there is one that has some advantage that makes the cell to proliferate, but the others are hidden. During the evolution of the disease, and that's what we don't understand, some of this predominant cell at the beginning starts to disappear. In some of them, clearly is because the treatment that we give is so efficient that kills all these cells. And then the ones that are very small and that have not an advantage, because there was the other big one, when this big one disappears, these other that are very small there, then they start to expand, yes, but because they don't have the competition of the big one. What are the factors? That's what we are learning for studying different time points of the disease. What are the factors that makes at the beginning one of them to predominate and the evolution release the competition to the others? Those are factors that we don't know. Some of them could be acquisition of additional mutations. Another one could be the treatment that we give to the patients that kill some of the cells and then allow them to proliferate. So I think those are the... Eventually you say you are a mathematician. I think there must be a way to understand how these cells combine, and must be models to help us to interpret how these cells live together, and some of them...
Thank you. It's a very, of course, well, it's a classical important problem in mathematics also, the modeling of this is, yeah, thank you.
Další otázka, prosím.
First of all, thank you very much for these excellent lectures. I got two questions. One is related to childhood acute lymphoblastic leukemia. It is, if I understood well, it is supposed that it is first occurring mutation during prenatal life, and the second one in postnatal life, in time when infectious stimuli are coming. And it seems that it is not only pathogenic microbes which are involved, but there is very important interaction with immune system, with microbiota. Are there some approaches trying to manipulate this interaction to prevent this disease?
It's actually an excellent question, and I'm a little bit ashamed to talk about immunology here in the presence of several real immunologists, but indeed that's one of the line of the research in the field, and Professor Greaves from London, who's the guru of the field, and I've mentioned his name several times, he actually proposes the idea of priming the immune system by a combination of specific antigen stimuli. In popular talks, he's talking about yogurt, kind of yogurt that would produce the correct stimuli. But I think that in reality there are some mice experiment, but in reality we are quite far away from the definitive solution of that.
Thank you. And the second question, it seems that antibiotic treatment during early postnatal life is very influencing the development of the immune system, and there are studies which are in metabolic diseases showing that there is a difference between large cohorts of children which are treated frequently with antibiotics and the other which are not so. This is mainly the work of Professor Blazer from States. I would like to ask if such a similar approach was used in case of leukemias.
I must admit I'm not aware of such a study in pediatric ALL, but what is known, when I shown you the graph showing the cumulative incidence in the particular age groups, when you look at the same curve in the developing countries, you don't see this peak between 2 and 5 years of age. The incidence is almost flat. So clearly there is a difference in something. I don't know if it's, I can't tell if it's antibiotic treatment in the early childhood or if it's hygienic standards, if it's other things in our environment. It might not even be a infectious agent. We are not sure about that. It can be any kind of antigen stimulus. So, but I'm not aware of such a study. It's obviously an interesting idea.
Thank you.
I was very much wondering with the last lecture about your talk about caspase 3. If you have just enough caspase 3 and just temporarily in proper amount is necessary for further development and for the life, and if you have a permanent exposition to caspase 3, it leads to the cell death. My field is metabolism, and we have some similar perspective of the insulin resistance, which was generally thought it is very pathological process, but we know that some level of the insulin resistance is very necessary for metabolic flexibility and for the interorgan fuel, and only permanent insulin resistance leads to the disease. And we can see similar things in the immune response and inflammation. You need inflammation to combat infection, but even if there is a permanent or very extensive inflammation, it is disease. So my question is, if this balance between proper and only temporary exposition to some physiological aspects and their permanent exposition is something what could be somehow more generally expressed as a little bit more general principle, because in the education of medicine we have physiology and pathophysiology, which from this point is a little bit nonsense. This is the same principle which in some extension leads to the disease. So my question is, if you can translate it also in more processes in your work.
Well, for exactly what you are seeing, for example, for the model of clonal hematopoiesis, when you have an acute inflammation or infections, you induce some cytokines in the bone marrow to induce the production of myeloid cells. And as I show here, you have a skewing towards the myeloid lineage. And when you have a chronic inflammation, actually which occur in a lot of risk factors I mentioned, and aging because the cells, the telomere are shortened and the cells release some inflammatory cytokines, or in case of obesity, you release also some inflammation. And this inflammation, chronic inflammation, will select some clones which become resistant to the inflammatory cytokines, and we know, and leading to selection of mutation of TET2 or DMT3A or JAK2. And this one may lead to the production of abnormal myeloid cells, which induce, as I said here, atherosclerosis and diabetes and cirrhosis and a lot of chronic inflammation disease. And interestingly, when I showed what occurs in sickle cell disease is because the release of hemoglobin S, which bear mutations, which activate the toll receptor, which are responsible for the chronic inflammation too. And in this case, this patient died actually for early aging, exactly as people become more aging. And so we know now one things which aggravate the sickle cell disease is the fact to select some clonal hematopoiesis with abnormal neutrophils, which induce all of these complications, what we do see in aging. And which is different when we talk about chemotherapy, for example. We know, I wanted to show, like, for example, after ALL, 15% of the kids survivor, they will develop a clonal hematopoiesis, which may explain why they develop secondary malignancies and heart insufficiency even 20 years later. But here, usually the selection of the clone may be different because you are the clone which resist to chemotherapy are the one which express p53 mutation, for example, or gene repair mutation, which may allow the cells to have mutation and to still proliferate, although they have mutation. And these mutations are the key to develop in the future some leukemia or MDS and eventually some other cancer.
Thank you. There have been, there is the other question. Thank you.
Thank you very much for excellent presentations. I have two questions. One is concerning the genealogy of the precursor and evolution of the tumors inside a patient, having the kind of symbiosis in multiple clones switching in between during the lifespan. Obviously, that's done with a patient. And I'm curious, when we look into the healthy person, whether we can reveal some patterns of these dormant clones, and there is kind of a good luck or bad luck, maybe microbiome, maybe some infection being responsible for ongoing oncogenic process. So my question is whether more or less in everyone in us there is a time bomb clicking, and that what we more or less study, it's epiphenomenon that we focus on a patient and we get money for sequencing all these clones, and we are not aware about the piece of an iceberg which is below the water level. So the question is how often we can find potentially the hidden pattern of the precancerogenic clones.
We are studying that in. It's difficult to. I mean, I don't know how to answer for all types of cancers, because probably with age we know that there are more cancer, different types, but in the tumors that we are studying, that are the lymphoid, hematopoietic system in the lymphoid tumors, for instance, we know that in this disease, in chronic lymphocytic leukemia, if we is increasing with age, And we know that if actually we are looking at healthy individuals with advanced age, we are detecting these clones with increasing frequency with the age in individuals that otherwise are completely healthy. So we know that with this particular disease, I am not sure with others, but this is the most common in the Western population, and we know that in these clones are detected more and more with age. What now we are learning is not just one clone, what these individuals have. They have multiple clones. We have counted, at least with these techniques, up to 6, 7 in the moment that, and they are healthy. They don't have any symptoms. We just detected by what make us think that the trigger, contrary to what we have seen in acute leukemia, that it seems that there is a mutation, particular mutation in utero that develops this clone. In these individuals that are multiple, we are studying if they have some mutations that we are detecting in some of them but not in others. So probably it's not a genetic event what is triggering. Perhaps there is a susceptibility in the genome of these individuals to allow certain clones to expand in the beginning. One idea that is emerging in the community is that might be a manifestation of immunosenescence, might be a way of the immunological system to respond to certain stimuli. Diversity has been reduced, so there are only some clones that are expanding, and for certain reasons they have generated a receptor that is giving signals to the cells to proliferate more than others. So we are, with this disease, I think we are changing a little bit our way of thinking of the tumors like one genetic event and then developing. Here what we are seeing probably is a certain susceptibility in the individual that increases with age, that triggers the development of many of these clones. Some of these clones probably will never expand to the level of a leukemia. We know that some of these individuals have clones that are there for many years and do not expand, but just are there. In others, they progress. And so it's a different way of thinking of this disease. And obviously they are open new questions. Why some of these clones remain and not progress? What are the others that progress? What are the reasons for that? And what we are discussing today, how are the interactions between all of them? And another element, what is the interactions with the immunological milieu that are controlling or not controlling these different expansions. So I think we are a little bit changing our mentality from thinking of one single cell, one tumor, to a group of cells interacting with the immunological system, creating an ecosystem, and perhaps we are trying to start thinking of tumors as ecosystems that evolve together. And to understand these systems is one of the challenges that we have now in early development of tumors.
Thank you. I have one more simple question. When you showed all these different clones, the cells were taken only from peripheral blood, or you also got cells from lymphoid organs where, for example, for B cells there is so high majority, maybe that the real number of clones is higher and they are kind of hidden somewhere in thymus or in spleen or somewhere else? Curious question.
Definitely is your view. I mean, I mentioned these patients in which we have been able to detect cells, up to 6, 7 different clones originated in different single cells, but by using not cells, but using sequencing of the immunoglobulin gene, that obviously we extract DNA and we are looking at the bulk DNA of the blood. By looking at the sequence of the immunoglobulin genes, we are detecting in some patients many more, even more than 10, in some of them closer to hundreds. The question is if these clones that we see little expanded are really already the disease, CLL, or they are normal reactive B cells that are expanding. And with the DNA, we are able to detect expansions, but not the cells. What we see now with the single cell analysis is that the transcriptome of these multiple clones are really similar to the leukemia, so I think they are leukemic. We have some hints that at level of the DNA makes us think that they are really already cells that have transformed, because there are some sequences of the B cell receptor that only have been seen in disease, not in healthy individuals, what is called stereotype B cell receptors, or B cell receptors that react with, that they have the same sequence, only seen in CLL. Now we are detecting these sequences in apparently healthy individuals at very low levels. So I think it's the idea of multiple clones being generated in some individuals is becoming more evident to me.
So thank you so much. Thank you so much for all the questions. So we are already behind our time scheme. I have a lot of the questions to all speakers, but we can reserve, so we probably can meet and can discuss individually. So I would like, first of all, thank to the Learn Society and the Czech Medical Academy to allow us to organize this meeting. I would like to thank all the speakers, especially both they come from abroad and are coming back tonight or early tomorrow morning. So thank you so much, and I think it's a great opportunity to discuss this fascinating field, and I wish you the good time. Thank you so much.